Thank you. Here are my disclosures. What do we know about Omicron? We know that Omicron is characterized by high transmissibility, can infect people who were previously infected by other variants of SARS-CoV-2, and it can also commonly infect people that were previously vaccinated against SARS-CoV-2. In England, Omicron, the sublineage BA1, has largely replaced the Delta variant within the epidemic. And in recent weeks, we have also seen increasing transmission of the BA2 sublineage of Omicron. A high number of infections are being caused by Omicron in the population in the UK and elsewhere. In the UK, this is happening on a background of high rates of vaccination against SARS-CoV-2. As of the 23rd of February, 85% of those aged 12 and above had received a primary course of vaccination, and 66% had received a booster dose of vaccination. And we can see that during the Omicron wave, the number of patients requiring mechanical ventilation and the number of deaths related to COVID-19 have not reached the peaks that were observed during the Delta wave. And a recent analysis of hospitalized patients in England has confirmed that the risk of admission into intensive care is substantially reduced with Omicron compared to Delta. These data from the UK and other settings show a lower risk of critical disease during the Omicron wave. But what is the mechanism? Well, the mechanism could reflect both a situation where there is a high level of immunity in the population, immunity conferred by vaccination and or infection. But it could also be a factor related to intrinsic differences in the pathogenicity of Omicron, or perhaps both mechanisms are at play. Now, we are all familiar with the concept that Omicron is characterized by a large number of mutations in the spike, more than 30 mutations that have been identified, including many mutations that occur in the receptor binding domain. It can therefore be anticipated that there will be potential escape from immunorecognition of the spike, where immune responses have been primed by vaccines that use the spike of the ancestral strain as a reference. And indeed, partial escape from vaccine-induced immunity has been observed with Omicron. Populations that have received a primary course of vaccination typically show relatively low titers of neutralizing antibodies against Omicron, although this is variable by vaccine type, by interval of vaccine doses, and also by population. The good news, however, is that a booster dose of vaccination with one of the available vaccines, with most data related to the use of an mRNA vaccine, the booster leads to a substantial improvement in both the quantity and the quality of humoral responses and cross-recognition of Omicron. What about CD4 and CD8 T cells? We know that they are impacted, those directed against the spike, primed by vaccination. They are impacted in their ability to recognize the Omicron. However, this is to a lesser extent than the impact we see on neutralizing antibodies. So based on emerging evidence, a lot of this is still under review, we can say that T cells primed by currently available vaccines appear to be holding up against Omicron. But let's look at some data. These are interesting data from healthcare workers in London that received 2 doses of either the BNT mRNA vaccine or the AstraZeneca vaccine. And the investigators looked at the proportion of participants that had detectable neutralizing antibodies against Omicron at median 4 weeks and 14 weeks after the second vaccine dose. And results indicated that the proportion able to neutralize Omicron was higher in those that had received the BNT vaccine compared to those that had received the AstraZeneca vaccine. And in the latter group, responses were improved by experiencing COVID-19 between the 2 vaccine doses, but were rather poor in those that did not have COVID before the second vaccine dose. So overall, we can say that these results indicate that vaccination with an mRNA vaccine leads to stronger neutralizing responses against Omicron. Another set of interesting data comes from a study that looked at SARS-CoV-2 naive participants that received 2 doses of the BNT vaccine, either 4 weeks or 16 weeks apart. And the investigators were able to demonstrate that the titers of neutralizing antibodies, including those against Omicron, were higher when measured 3 weeks after vaccine 2. They were higher if the interval between the 2 doses was longer. So these are the interesting data that will need, of course, more studies to be confirmed. What about the impact of a third vaccine dose? This is a study looking at participants without a prior or intercurrent SARS-CoV-2 infection who received 3 doses of an mRNA vaccine, most typically the BNT vaccine. And they were sampled at regular intervals after vaccine dose 1, 2, and 3. What the investigators found was that if we look at data for the ancestral strain, we can see that the neutralizing titers declined after about 5 months after the second vaccine dose, but were significantly boosted when measured 1 month after the third vaccine dose. What about Omicron? We can see that antibody titers, neutralizing titers, were low after 2 doses of vaccination, but there was a substantial improvement with a 37-fold increase in recognition after a month after the third vaccine dose. So we can say that, yes, titers against Omicron remained about 16-fold lower than against the ancestral strain of SARS-CoV-2. However, there was a substantial boosting of the quantity of neutralizing antibodies against Omicron in this population. The investigators went further and also looked at the impact of the third dose of vaccination on the memory B-cell compartment. They were able to show an increase with the third dose in memory B-cells specific for spike, and the increase was due to both an expansion of pre-existing memory B-cell clones and also emergence of new B-cell singlets and clones. There was also an evolution in terms of the quality of the antibodies in these memory compartments. For instance, there were differences in epitope distribution when comparing vaccine dose 2 with vaccine dose 3. Overall, the response showed increased potency and breadth. It targeted more conserved regions of the receptor binding domain. And as we can see here, it is true that when looking at the proportion of neutralizing and non-neutralizing antibodies, Omicron is impacted more than other variants, but nonetheless, more than 50% of the antibodies in this analysis were able to neutralize Omicron. So we can say that the third mRNA vaccine dose has a positive impact on the quality of the humoral immune response within the memory B-cell compartment, which is good news. Coming back to the T-cell recognition of Omicron, a study predicted using epitope mapping combined with TCR repertoire sequencing predicted how the mutations occurring in the spike of Omicron will affect T-cell recognition among those that have been primed by vaccination. And basically the study predicted that 33% of CD4 and 21% of CD8 recognition will potentially be affected, which is a larger impact than seen with other variants. Reassuringly, there was a minimal impact on T-cell responses targeted to non-spike regions of Omicron. Now, these data are being confirmed and several emerging studies have indeed shown, using ex vivo experiments, that there is an impact of the mutations occurring in the Omicron spike on T-cell recognition among vaccinated participants. There is a decrease of 15 to 30% for CD4 recognition, 15-25% for CD8 recognition. But overall, although impacted, between 70 and 80% of T-cell immune recognition of Omicron is preserved in vaccine recipients, which is very good news. Should be noted that in some of the study, a subset of participants appear to completely lose recognition by CD8 of Omicron. And of course, we need to do more studies to understand what the significance is of this observation in terms of protection against severe disease. Coming now on to effectiveness studies, the study here from Israel looked at the benefits of providing a third dose of the BNT vaccine to a population that was compared in this study to a population that did not receive the boosting dose of vaccination. And this population was matched, the control population was matched for demographic and clinical factors, including the number of risk factors for severe COVID-19. And overall, in this study, investigators were able to show that the third vaccine dose had a substantial benefit in terms of reducing the risk of hospitalization, severe disease, and death. So these were very important results to show the benefit of giving a third dose of the mRNA vaccine, the BNT vaccine. And there were no differences in terms of sex, gender, or number of comorbidities. The separation in the curves between people who were given the booster dose in red and those who did not receive boosting in blue, the sort of separation of the curves occurred around about a week after boosting for risk of hospitalization, and about a week to 9 days for risk of severe COVID-19 and mortality. Now, a number of observations. The third dose here was given between July and September 2021. Follow-up was quite short, so obviously we need longevity data. And also the study excluded several key populations, including patients who are immunocompromised. Another interesting set of data comes from a study in South Africa of healthcare workers that received 2 doses of the Johnson & Johnson adenovirus vectored vaccine. The first dose was given during the beta and then the delta wave of infection, and the second dose was given during the Omicron wave. There were a large number of infections due to Omicron during the study, over 30,000. Looking at hospitalized patients, however, the requirement for oxygen therapy at any time was significantly reduced during the Omicron period compared to the Delta period, and also the requirement for ventilation was significantly reduced. There were also some interesting differences in the Omicron versus the Delta population in terms of hospitalized patients. With Omicron, more females, younger people, fewer people with hypertension or diabetes, and a few more people with HIV. The investigators ran a case control study of the healthcare worker population, comparing those who were vaccinated with populations that were not vaccinated, after matching for demographic and clinical factors, including number of risk factors for severe COVID-19. And they were able to show that a single dose of the J&J vaccine was effective versus no vaccination in preventing hospitalization, admission into intensive care, and mortality. And they also analyzed the effect on hospitalization of giving the second dose, and could see that indeed there was a benefit at 1 to 2 months against hospitalization, with further analysis pending at the moment at this stage of the study. So these are preliminary data that clearly indicate the benefit of giving a second dose of the J&J vaccine. Now, the study was also interesting because the initial analysis indicated that after a single vaccine dose, people with HIV actually did not benefit as much as the total, when compared to the total population, did not benefit as much in terms of reduced risk of mortality, with a vaccine effectiveness of only 14%. We definitely need more data to understand the risk in people with HIV in terms of COVID-19 in the context of vaccination. Some interesting data are starting to emerge for patients with immunodysfunction. This is an analysis of the N3C cohort that collects patient-level data from 60 centers across the US. The population analyzed in this study received a primary vaccination, predominantly with an mRNA vaccine, 2 doses, usually the BNT vaccine. 5% of the population received a single dose of the J&J vaccine. A subset of 174,000 or so received a booster vaccine between August 21 and January 22, again, mostly with the BNT vaccine. The first analysis looked at the risk of breakthrough infections in booster recipients. And the first observation was that indeed the number of breakthrough infections increased in booster recipients when Omicron became dominant, which is not surprising based on what we have understood so far. But the analysis showed that in the populations without immunodysfunction, there was a substantial benefit, substantial effectiveness of the booster in terms of preventing breakthrough infections. There was also a good impact, good effectiveness of the booster dose in the population with immunodysfunction. Although one should clarify that the group with immunodysfunction was rather heterogeneous because it included people with HIV, as well as transplant recipients, people with cancer, people with autoimmune disease. Nonetheless, good news in terms of the impact of a booster vaccination on the risk of breakthrough infection in both people with and without immunodysfunction. Along the same lines, also very important initial findings from the study in the ability of the booster dose to prevent adverse C19 outcomes, COVID-19 related outcomes, both in terms of hospitalization, in need for invasive ventilation, but also in terms of risk of mortality. And again, in this study, they were able to see the benefit in people both without immunodysfunction and in the group with immunodysfunction, after controlling for a number of important parameters. So what can we conclude from this initial analysis, from this emerging data, is that boosters appear to have an important impact on the risk of infection and on the risk of adverse COVID-19 related outcomes during the Omicron transmission, at a time when Omicron transmission is dominant. We need more data about populations at risk, including improved analysis for patients with HIV. We know that the risk of severe COVID-19 is not uniform in populations with HIV, with a subset experiencing a greater risk of severe disease. And we are also starting to see data that indicate that responsiveness to vaccination also vary among different populations with HIV. In Rome, we analyzed a prospective cohort of people with HIV who received 2 doses of the BNT vaccine, given a median of 3 weeks apart. This was an interesting population because about 47% of them had a history of previous advanced and severe HIV infection with AIDS or a CD4 count below 200. The current median CD4 count, however, was high at 710. And this population was doing very well on antiretroviral therapy. However, there was a subset of around almost 10% that had HIV viremia. However, the viremia, should be noted, was at low level with a median of 122 copies. Now, in this group, we measured anti-S, anti-spike titers. These were just IgG. in relation to the CD4 count and other parameters 4 weeks after the second vaccine dose. There was a significant impact of the CD4 count, as we can see, with significant differences in antibody titers when comparing people with a CD4 count below 350 with those that had higher CD4 counts. And in multivariable linear regression analysis, we identified a number of predictors of anti-spike titers in this population. In particular, having a prior SARS-CoV-2 infection, not surprisingly, increased the antibody titer after the second dose of the vaccine. But also there was a positive impact on titers of African ethnicity, which was maintained after adjustment and deserves further investigation. A number of parameters impacted negatively on the antibody titers. Injecting drug use was associated with reduced titers. The CD4 count, as we said, both for a CD4 count between 200 and 350, but even more so if the CD4 count was below 200. Interestingly, in this population, viremia, despite being at a very low level, was an independent predictor of reduced antibody responses to vaccination. So these emerging data started to identify some factors that predict reduced responsiveness to vaccination in people living with HIV, and therefore may guide policy around boosting and further vaccination strategies. So coming to the end, what are the key takeaway points at this moment in time is that vaccines encoding the ancestral spike induce cross-reactive neutralizing antibodies and CD4 and CD8 reactivities against Omicron. However, there is a substantial escape from neutralization, although boosters improve both the quantity and the quality of humoral cross-recognition. And this is true and demonstrated for mRNA vaccines. In terms of T cells, we know that there are abundant T cell epitopes across the entire spike, including some of the conserved regions of the spike. And indeed, Omicron spike recognition by CD4 and CD8 cells is largely preserved. We believe that a coordinated humoral and cellular adaptive immunoresponse likely accounts for reduced morbidity and mortality from infection with Omicron, as seen in cohorts, in multiple cohorts. However, we need more data on the longevity. And also we need to dissect the effectiveness of vaccines and boosters across the different cohorts, different because of different vaccine types, because of SARS-CoV-2 infection status, age, comorbidities, HIV status, and so forth. Thank you very much.